speaker, I'd like to just mention a few housekeeping items. We will be sending out a survey following the event, and we appreciate your feedback. We will also be taking a few pictures, mostly from the back. On your way out, please don't forget to pick up your CE certificates and a schedule for the upcoming events. Our next one is on Tuesday, May 21st, and the topic is to be announced soon. And finally, at the end of the night, if anybody would like a tour, please see me. I'm happy to show you around the hospital. With that, it's my pleasure to introduce a familiar face, Dr. Brad Coolman. Dr. Coolman has been our managing DVM since I was born in 2003. Long before those titles, he was served as favorite son to one of our founders, Dr. Roy Coolman. He graduated from Purdue in 1992, completed his internship at Auburn University in 93, served as Chief of Surgery and Dentistry for the Army Military Working Dog Center from 93 to 96, completed his residency and master's degree at the University of Illinois in 1999, at which point he and his family moved back to Fort Wayne to join us here, and then earned his board certification in 2000. This summer, Brad will be celebrating his 20th anniversary here at Knives, and has enjoyed supporting our referral community on a variety of complex surgical procedures. Please welcome back, Dr. Brad.
Well, thank you for coming, and if you didn't get coffee or cookies, it won't hurt my feelings if you get up and help yourself while we're talking, and if you get up and leave, I'll know I should stop. So I just want to start a little bit on a solemn note. Some of you know, most of you know, but maybe not all of you, that one of our doctors passed away last week, and her funeral was today, and that's Carol Scott Myers. And Dr. Scott had worked in emergency medicine for a long time. She actually came with the emergency clinic when it came to this facility 25 years ago or so. I think she started ECAC in like the late 80s, like 89 or 90, something like that. She was diagnosed a little over a year ago with multiple myeloma that was very aggressive, and went through some pretty significant treatment. Unfortunately, did not win that battle. So we're just going to have a moment of silence to remember Carol and her contributions. Thank you. As most of you know, many of you may know that I'm at the end of a little period of sabbatical, which I've been very fortunate to have since October, and that just a couple of weeks away. I'll be back in the trenches full time, and I'm actually looking forward to that. One of the things that I've been doing, in addition to some travel and some personal reflection, spending some time with my family, has been a lot of reading, which I love. And so one of the books I wanted to read during this period, and I read pretty much the whole thing, is called Complications of Small Animal Surgery. And I realized after about the third chapter that I probably should have written this book because I created probably most of the complications or dealt with most of the ones in there. So that's actually part of the stimulation in my mind to for this topic. And it's going to be a little more of a philosophical talk, and as Andre said, I graduated from vet school 27 years ago. There's some people in this room graduated long before that, and some of you weren't born 27 years ago, so there's kind of a wide range in this audience. One of my mentors at the University of Illinois, Andre, did you dim that light, or can you maybe? So if they can see this, was Dr. Bill Smith. He unfortunately passed away 2 years ago as well. But he used to like to say, some doctors practice for 40 years, and some doctors practice 1 year 40 times. I guess I can let everyone in the room decide where they fall on that scale. But it's kind of a humorous way of saying, that sometimes people don't really advance from whatever year they graduated from vet school, and they're still doing things exactly the same way. And that could be one of the reasons maybe why we see some challenging cases or complications. For sure, it's important to realize that all human beings make mistakes. Every one of us is prone to errors, and another one of my personal heroes, and I'll make a shout out to Atul Gawande. I don't know if you've ever read any of his books. There's several, and I'll mention a couple of them in this. He also wrote a book about complications, and one of the things that he makes a point in there is that most of the time in human medicine, when there are medical errors, it's not because it's a gravely evil or bad person. It's just either some unfortunate event or just the human side of dealing with the challenges of medicine and surgery, etc. And so the bigger thing, I think, and maybe the point of this talk is really, do we learn from errors that we make, and how can we prevent, or what can we do to put things in place to help minimize complications? So part of the way to maybe illustrate some of these is just to reflect on some personal experiences. So I'm going to roll you back 28 years ago. When I was a fourth-year vet student, my very first rotation was in small animal surgery, and my very first week in my senior year, which was in May of '91, I was thrown into ICU because they assigned you to work certain shifts in ICU. So I literally, it was probably my second or third day in the clinics as a fourth-year vet student. And there was a puppy that was in there. This is not its actual picture, but I think it looked pretty much like this. A little German Shepherd puppy that had a PDA surgery that day, and I was in charge of its care that night with the IC overnight tech. And so the surgical resident had said, if the dog's painful, give it some butorphanol at such and such a dose. I'd never administered butorphanol to anything in my life, so okay. The dog was acting painful. I asked the ICU tech, should we give butorphanol? She said, sure. I did the calculation. Okay. Asked her if it looked right. I think she glanced at it and said, yeah, that's probably right. It was just off by 1 decimal place, so instead of giving it 0.1 mils, I think I gave it a mil. As I gave it, I thought, this is not a very big dog, and I wonder if this is really right. So I sat back down, and I kind of did the math a little more, and I realized that I had given the dog maybe 10 times too much. So thankfully, butorphanol is a pretty safe drug and has a sealing effect and is not something that causes serious error, but believe me, I was sweating bullets. So then I went to the ICU tech and said, I think I gave too much. And she went over with me and said, oh my gosh, what do you do? Well, call the resident, he's out to dinner with his friends. He, thankfully said, it'll probably be okay, just watch these parameters, and did fine. But the point of that is just, this was very early in my career. It wasn't even a veterinarian yet, and was one of those experiences that you never forget because, wow, what if that had been something that could have killed that dog, or something that had a much more narrow therapeutic window or whatever. And it always impacted me because from then on, whenever I was calculating drug doses, I had at a little higher level of vigilance. So again, just an example. During my internship at Auburn University, had a great experience there. I remember I was on a surgery rotation, and it would have been in October because the ACVS National Surgery Meeting, I believe, was in Florida that year, somewhere in Orlando or something. And I look back at my internship, and it's kind of amazing. Things have changed a lot, which makes me feel old. But in those days, if you were an intern and you were on call and a surgery came in, they expected you to do it. You didn't call in the surgeons, you just did it. And I'm like, so I've been out of vet school for a few months, and I'm an intern on call, and I'm doing back surgeries and other things. And nowadays we wouldn't let the interns do anything but maybe close the skin. So all the surgeons at Auburn, including all the orthopods and all the soft tissue surgeons, went to the ACVS meeting. And all the residents went to the ACVS meeting. And since I was the intern on surgery, they left me in charge. They left me with 5 students who I was supposed to teach in rounds, and we won't schedule anything, but if anything comes in, you got to deal with it. Well, this Dalmatian came in, not this exact Dalmatian, but one that looked like it, and it was in renal failure, and it had both kidneys had stones, and this is not its X-ray. I just found an X-ray on the internet, but the stones were probably 3 times bigger than that in both kidneys. I mean, they were huge. and the dog was very sick, and somehow it ended up in our care. So, of course, thankfully we were consulting with internal medicine, and we had the diuresing the dog and treating it medically to try to bring the kidney values down. But somehow the discussion was, should these stones be taken out of the kidneys? Well, you know, I've only been a veterinarian for like 4 or 5 months, and I love surgery, yes, but this is not just a minor procedure, right? So the long and the short of this case was that I think one of the surgeons got back who was supposed to be on with me but had been gone for the meeting, like on a Wednesday night or a Thursday, and he had plans that weekend, and I asked him about it, and he said, okay, we'll just take the stones out tomorrow. So and I'm like, okay, so we scheduled it for surgery, came in. If you've ever done a nephrectomy or a nephrotomy on a laid a kidney open that was diseased, they bleed like crazy, all right? So we took both kidney stones out, or he took both kidney stones out, I helped, bloody, horrible mess, sewed them back together, and then he left, and left me with the dog for like a long weekend, and the dog was like teetering on life and death, and its kidneys were failing, and the dog's name, I never forget the dog's name, I don't remember many patients from 25 years ago, it was Pokey, and wonderful owners, and Pokey was in ICU for about 10 days, and finally died. And I was so frustrated because this surgeon basically just waltzed in, took these stones out, left the building, left town, and it was really more of what I would consider an error in judgment. So that's the point of that case. So then after I left Auburn, I was in the U.S. Army Vet Corps, another great experience, 3 years in San Antonio, Texas, and I worked with the military working dog program. About 70% of the dogs we had were Belgian Malinois. If you've ever been around the Belgian Malinois, they are crazy. They go. They're very high drive. And a lot of those dogs, when they weren't being worked, would sit in their cage, and we called them spinners. They'd spin in circles, because they had so much energy. And a lot of times they'd get a lesion on their tail from the concrete, or hit their tail on the cage door where they spun. And once it started bleeding, you could try to treat it medically, but it was a no-brainer. You just had to do a tail amputation. And so I cut off a lot of dog tails during my 3 years in the Army. Very good at tail amputations. And that's not me doing a tail amputation, because you'd never leave that much stub, because then they'd have just leave enough to take their temperature. So my hand was about the ideal length of a military dog's tail if they had ever cut off. I'll never forget, we had a dog named Nero who was about as mean as Satan, and my Army tech had forgot to check the level of isoflurane in the vaporizer, so it was basically running on fumes. And we moved the dog into surgery, and the table's kind of like this, and I put the towel clamps on, and I started to cut, and Nero came off the table. Thankfully his back legs were still tied, kind of angled like this, but his front end came around like this, and all the instrument tray went flying, and it was quite a scene to get him subdued before he realized that he had been not appreciating me trying to cut his tail off. So again, that's an example of a complication that was really lack of attention to detail. One other tail amputation story I'll never forget was a dog that we removed the tail the day before. We always put a purse string in their anus, because we were working fairly close to that area. And the next morning came in to do physicals, and one of the dog handlers, who was a retired Navy policeman, he said, "Hey doc, you took him out, he's trying to take a crap, but he can't get anything out." He's like, "Bring him in, let's take a look." He still had his purse string in, so that was another sort of complication that was fairly easily rectified, pardon again, just an example of either lack of attention to detail. So from then on, every dog had a piece of tape on its head that said purse string when they went into the OR, so that we'd remember to remove that when they woke up from anesthesia. All right, here's another case that's one of those kind of imprinted deeply in my mind. So this was in the end of the first year of my surgical residency at Illinois, and we had a dog transferred from internal medicine that was about a 95-pound golden. It probably should have weighed 60 pounds. It was quite obese and very cushianoid. Yeah, very normal probably for most adults these days. Very cushingoid, very big pot belly, and it had been diagnosed with a functional adrenal tumor by the internal medicine and oncology services. So had a large right-sided adrenal tumor, and was functional, so the dog was, PUPD and overweight and very endocrine, and they had wanted us to take the tumor out. So great, never done that before, but I'm excited. Working with one of my mentors who was a great soft tissue surgeon, Sandy Manfred, and we were going to have to do a combined approach where we opened the flank along the right side of the rib cage as well as here to really enroll the table to get to this tumor, because it was size of a little bit smaller than a racquetball, maybe tennis ball size, and pushing into the cava. So they're prepping the dog for surgery, and of course I've been, prepping for this all night, and reading everything, and trying to get psyched up and excited about it. And the anesthesiologist on the case was Dr. John Benson. So I just threw that book up there to say he was Tranquilli and Benson were the two anesthesiologists. Thurman was their mentor at the University of Illinois, that pretty famous group. And the thing about Dr. Benson was he was always negative. Just one of those people you remember that was always scowling about something. But that morning, while they're prepping the dog, I mean, he was especially grouchy. And so I had been there working around there long enough that I said, Dr. Benson, like, what's going on? Toast burnt this morning, and you are really grouchy. He said, I've been here 20 years. I've never seen someone take out an adrenal tumor. Every single dog dies on the table or dies in ICU. This is my first adrenal tumor. I'm like, what? Never? Yeah, never. I don't even know why. They should just euthanize these dogs, So that was a good, pump me up, ready to go in and jump in on this case. So we took the dog to surgery, and again, this is not the actual case, is one I pulled off the internet as well, but just to give you an idea, I mean, how deep it is, and that's actually, the tumor is probably smaller than the one that we took out on this dog, but adrenal tumors are highly vascular, highly invasive, and usually deep, and especially when you're in a very, very obese dog, they can be a real challenge. And the long and the short of this story was, we got the tumor out, and the dog lived. So I every time we had an adrenal tumor after that, I made sure I talked with Dr. Benson to remind him that he had seen the first one live, and he didn't appreciate that either. But the point of this surgery is not that there were complications, although these cases are fraught with complications. The point was more to bring out that sometimes you remember people that you've worked with or seen that seemed especially burned out. And Dr. Benson was probably one of the greatest examples of that I can think of. All right, so another topic that is kind of near and dear to my heart, especially during this period of sabbatical, been doing some research and reading about compassion fatigue and stress and burnout, which is especially, I think, relevant to all of the healing professions and germane to veterinarians. And so just kind of a little side note on during my talk here because of that last example. So most veterinarians in this room that have practiced more than a few weeks or months, especially a few years, can relate to exhaustion and just tiredness, fatigue, and I know all the vet techs and assistants in the room can as well. And because we work long hours and a lot of what we do is hard work, whether it's emotionally, physically, or in other ways. There's a lot of demands. Stress is kind of the next level down, and the reasons for stress are usually related to human beings, whether that's coworkers, bosses, clients, pet owners, as well as the stress of working with patients that aren't always cooperative, and financial pressures that we all have in our personal lives. The next level then is burnout, being overwhelmed, feeling like you're ineffective, cynical, loss of control, or detachment. And just as a personal note, part of the reason that I'm taking this sabbatical is because I really probably was definitely well into that stage of burnout on many levels in my professional life. beyond that, you get into things that are much more serious. Compassion fatigue is something where change of scenery or change of environment is not going to fix that. It's deeper than that. Clinical depression, I mean, you start getting into things that need medication, and then I just threw in there a little bit about suicide. And the only reason is because some of the reading that I've done would suggest that the suicide risk for veterinarians is increasing. And one study said that 1 in 6 veterinarians have considered suicide, which means potentially people in this room or people that we know. It's actually a higher risk for females than males, and compared to the national average. So again, I just wanted to take a second and say that certainly there can be a correlation between complications and errors in practice and in human medicine. Lawsuits are directly related to kind of going along the scale where people start to either not care or not have the capacity for empathy or for doing their job well. And it's something where I think it's important for all of us to have a level of self-care for each other and personally, and just kind of an awareness issue. So enough said about that. Okay, so if you've never read a book by Atul Gawande, I really can't recommend him strongly enough. He's like a Rhodes Scholar. He's a human surgeon, and his writing is, if you enjoy a good book, very interesting. This book is very one I've read it several times actually, and recommended to several people. But again, read it for the first time a number of years ago, and that also is sort of an impetus for this topic. So let's just shift gears a little bit. And everyone who's worked around a surgeon has probably heard the phrase, "a chance to cut is a chance to cure." And another way of saying that for me is every patient needs surgery. It's just a matter of figuring out what surgery they need. But remember that a chance to cut is also a chance to create complications. So whenever you're recommending or performing surgery, you certainly need to keep that in mind, keep that balance. So we just want to think about sort of general complications that can happen after a surgery, maybe slightly in increasing order of seriousness. These are some of the things we would think about: edema, seroma, bleeding, inflammation, infection, suture reaction, implant failures, wound dehiscence, tissue necrosis, or death. That's probably the ultimate complication. And if we kind of just think at a philosophical level about why complications occur, and this was sort of the point of maybe my first few examples, lack of experience. So given the wrong dose of the drug because you've never pulled that up before, or maybe a surgical error because you've never done that surgery before and you didn't have someone helping you through it. Lack of planning. I think the Dalmatian, here's a dog that maybe it did need those kidney stones out, but it certainly wasn't. It was just kind of rushed into by the person who did it without a lot of discussion and aftercare, if you want to say it that way. Time pressures. Hey, we don't have time to do this. We just got to get through it really quick. Obviously, that can lead to complications. Mistakes. Just forgot to check the vaporizer. Forgot to take the purse string out. Forgot to take the sponge out of the abdomen. Whatever. Judgment errors. Attention to detail. That would be another one. Refusing help. So, again, there's definitely a correlation from those who are willing to listen to their assistants or their technicians, as well as the other veterinarians, and seek help when it's maybe something that they're not as comfortable with or not as experienced with. And I would just, give a shout out to all the techs and assistants in the room, because, that's a hard thing. Many of you are placed in positions where you're working with, maybe a veterinarian who may not be as open to feedback, but we count on you, and I certainly count on our technicians in our hospital to say, hey, Dr. Brad, weren't you going to put a screw in that last hole? Or something like that, and I might say, that's a good idea. I think I will put a screw in that last hole. It'll look better on the x-rays. So just, having the nerve to say something, and then being open to receiving that feedback. And then, as sort of I mentioned too, compassion fatigue. like I said, in human surgery, there's definitely a correlation with serious medical errors and with lawsuits based on stress and burnout characteristics. So sometimes the complications occur because of compliance issues, the patient or the owner. My personal experience, and again, I'm just talking from the 27 years that I've been doing this, and most of that time has been in surgery, I think a lot of veterinarians tend to blame the owner or blame the pet too early for the complication. So, not saying that our patients don't, you know, I've had dogs hanging from their external fixator on a chain link fence. Like, that's not my fault, you know, that's probably but maybe I shouldn't have put an external fixator on that crazy Weimaraner. Maybe I should have thought that that's something that dog was going to do. So, there's still always those things we have to keep in mind. There are sometimes just bad luck. I remember a dog once that had fractured humerus. It was a big dog, I think it was a retriever, and it came back for its follow-up 2-month x-rays. It healed beautifully. We sedated the dog, we took x-rays, great. On their way home, someone pulled out in front of the lady, she had to slam on her brakes, the dog slid off and it broke its other humerus. I mean, that was just bad luck. I mean, that was... And then I threw on here acts of God because that's used in the insurance industry. I'll never forget, probably the second year I was here at Knives, and there was a dog that was sent over from Ohio, an older veterinarian who was in a mixed practice, had sent the dog over for an ACL surgery. It was a big, I don't know, shepherd type dog, and healthy, blood work was normal, no concurrent disease. It was probably a 4 or 5 year old dog. We did the surgery, everything went fine. Anesthesia was turned off. We were literally moving the dog out of the OR, and someone said, his tongue looks really blue. So we immediately hooked him up, and the dog went into cardiac arrest. Literally had been perfectly stable through the whole surgery and was technically done with surgery, and the dog died. We never got it back. It was very, very disappointing. So I called the veterinarian to tell him the bad news, and I was really bummed. I mean, it was just one of those things you just totally shouldn't have happened, don't know why it happened. And he said, I'll never forget when I graduated from Ohio State, 1950 or whatever, that the dean said to us, never forget this in your career. Said, when a person dies, they say, it was an act of God. When the cow dies, they say, it's that damn vet's fault. So anyways, that's my story about acts of God. So, all right. So this is the shout out to your team. One of my favorite sayings is there's no I in team. So if someone wants to be a Tim or a Tim, that's fine. It says at the bottom, you can't read that. There's no I in team, so the first thing we need to do is teach our spell checker to learn a new word, T-E-I-M instead of T-E-M. So use the people around you because they're gonna help you. There's always a tension in surgery between time and trauma. If you're delay and take too long to go through a surgery, you definitely can increase the risk of certain complications. If you rush and you're trying to hurry too much, you can create certain complications. So Dr. Steve Swain, who was a mentor of mine at Auburn, great guy, he used to say, don't rush, but hurry all you can, which I thought is kind of one of those things I've always kept with me. This little cartoon, where's the Vicryl I sutured with? And the anesthesia guy is saying, probably got absorbed already. So that surgery may have gone a little too long. Okay, so then if we just think about the complications that are probably most commonly encountered in the course of surgery, as far as general, we could go with any surgery, bleeding, inflammation, infection, or wound dehiscence. So those are probably the 4 biggies, I would say. If you specifically want to think about surgery in the abdominal cavity, you could also add herniation or even evisceration, adhesions, which could lead to things like bowel incarceration, and then I would add iatrogenic foreign bodies, so leaving something in the abdomen that wasn't supposed to be in there. As far as the orthopedic side, we could certainly have failure of implant or failure to heal, which would be a non-union, and then in addition to the superficial inflammation or infection, if there's a metallic implant or something left behind that's permanent, you could get a chronic infection or an implant-associated infection. All right, another pet peeve of mine is the phrase routine surgery. So those of you who are like 50 or over probably recognize this person. Maybe some of you may have never seen him before, but from the TV show MASH that was very popular for a long time. But there's a reason that I don't like the word routine surgery, and I was trying to figure out why, because I don't like when people say, oh, we just did a routine surgery. Is it a routine PDA or routine TPLO or routine spay or neuter? And I think as the more I thought about it, the first two definitions up there of routine are probably good things that we should want to do. So a routine is a usual series of things that you do at a particular time. So doing the same things the same way every time. So, you know, if you do a lot of spays, you probably have a very set order that you do it through. You don't have to think about it. Or physical exam, hopefully you do fairly systematically the same way every time. So that's actually a good thing, regularly doing things in a fixed order. The reason I don't like the word routine is probably that third one. You can use routine to refer to a way of life that is uninteresting and ordinary. And so the risk with routine is maybe making it boring or so kind of automatic that you disengage your brain a little bit, and that would be the bad side of routine. So I guess the bottom line for me is that it's good to have routines, and we probably all do and should have routines in our veterinary practice, but we should not approach surgery in a routine way because it's always interesting. I always like it. Sometimes I'll have younger veterinarians or new graduates who come by here and they say, oh, if you're going to have any interesting surgeries, would you call me so I can come over and see them? And I say, we'll come over any day because every surgery I do is interesting. Otherwise, I would do something else, right? So, okay, another thing that kind of ties into this idea of routine and has been clearly shown to help minimize or at least reduce infection rates, but not eliminate them completely, is the use of checklists. Another book, and that's the cover of the book, is called the Checklist Manifesto. I know it's hard to see other than the big check mark on the red background, but that's another book that was written by Gawande, another one I would encourage you to read. Checklists were originally really became standardized in the aviation industry, and believe it or not, there was a long period of time in the history of flight where pilots were resistant to that. I don't need a checklist, I'm an experienced pilot. But they realized that if they go through everything every time in the same order, that suddenly mistakes started becoming less and terrible accidents started happening less often. And that's evolved into the human side. And again, I think this is done pretty routinely, pardon the use of that word now, in human procedures, but not universally. And I know I recently had a diagnostic procedure, and before they knocked me out in a rope fall, which was crazy, I remember them saying, like, okay, we're going to do this. This is Brad Coolman, this is, and the other person, yeah, this is Brad Coolman, we're going to do this, yes, yes. And they were basically going through that checklist pre-operative or pre-procedure. What's been shown, there was a large meta-analysis, which means that basically